Social Venture Partners. Welcome to Social Venture Partners Mental Health Educational Panel. I am Karen Lindgren, Chair of SVP's Investment Selection Committee. We call ourselves the ISC. I'm Chair of the ISC this year, along with Jorge Mendez, our ISC co-chair. The ISC is tasked with recommending to the full SVP partnership a nonprofit mission investment focus for the coming year. And we have selected mental health as our mission focus that we will recommend for 2023. And we've invited our 6 panelists as well as the full SVP partnership to this event today, in addition to a number of special guests, in order to educate SVP and particularly the Investment Selection Committee on Boulder County community needs in the mental health area. Our goal here today is to gather information on various mental health related missions and nonprofits where SVP could most effectively deploy its resources and best exercise the capacity building skills of its partners to make a needed difference in this area. Our panel today will be moderated by Roland Evans, a longtime SVP partner who's been a clinical psychologist in private practice in Boulder for 40 years. Roland has also been a professor at Naropa for 15 years and currently supervises a mental health clinic in Zambia, as well as an amazing organization called Therapists for Ukraine. The plan today is for a 1-hour panel discussion moderated by Roland, followed by 30 minutes of Q&A. And we ask all participants to please type all your questions into the chat box, and we'll do our level best to get to all of them. So with that quick introduction, don't want to take any more time away from the panel. I will turn the mic over to Josh Silverstein, who is SVP's amazing CEO, and who will say a few words before Roland kicks off our panel discussion. Josh?
Thank you, Karen. Paris, Kathy, Dixie, Jenna, Marcy, on behalf of SVP Boulder County, thank you so much for joining us and sharing your expertise and insight today. At SVP, our motto is strong nonprofits equals strong communities. And this is another attempt for us to really see how we can really aid our community in becoming stronger and serving our youth and adults who suffer a lot silently. So thank you for joining us. And to the partners who are here today, thank you for witnessing this wonderful panel discussion. And it's my pleasure to turn it over to partner Roland Evans.
Right, thank you very much. Thanks, Josh. Thanks, Karen. So I'm going to introduce our panel. I hope that I've got your information right. Some of you have sent me stuff, and I've been kind of gathering information. If we'll talk a little bit about, you can add more information as we go along. But let me just go through who our panel is. First of all, let me see there. Thank you for coming, all of you. And I just looked at how much experience everybody has, and it's hundreds of years, it seems like. If you add it all up, there's so much experience here in lots of different areas. So I think we're able to really gather the information for SVP that we really need. So let me introduce, first of all, Paris Adler. She's the Executive Director of the National Alliance on Mental Illness in Boulder County. NAMI, which is the National Alliance, has 650 local and state chapters and provides advocacy, education, support, and public awareness for individuals and families affected by mental illness. She previously worked in financial services for large asset managers, focusing on strategy and technology. That about covers it, Paris? Okay, thanks. And I'm going to ask you to speak in a little while about your main satisfactions and interests in this field. Just quickly for each one of you, we'll go around, but we'll do this in a little way. So Kathy Valentine is the chair of the Hope Coalition of Boulder County. The mission is to educate the community about depression and suicide prevention. She's the executive director of Colley's Closet, which is a BBSD high school peer education organization. Those members have presented to over 60 classrooms during this school year on the topic of depression and suicide. And she's also the board chair of the Parents Engagement Network. That covers it, Kathy? Good, thank you. Okay, Dixie Casford is the co-CEO of Mental Health Partners in Boulder. They are the big kahuna, basically, in our community. So Mental Health Partners is a nonprofit that provides comprehensive mental health services to the community since 1962. Dixie is a licensed professional counselor with an MBA and a master's in legal studies, and she's worked in community mental health for the past 20 years. That covers it? Good, good. Okay, Bill. Bill Monroe is the director of Naropa Community Counseling. This provides outpatient mental health care to 500 Boulder area clients through graduate student interns and externs. The service is free to Medicare clients and charges a low fee of $30 an hour for self-pay. Bill's been involved in mental health care in the Boulder area for 20 years with Boulder County Public Health, Good Samaritan Medical Center, and Naropa University. Okay, good. Right, where are we now? Jenna. Hi, Jenna. Jenna Clinchard is the executive director of Rise Against Suicide, a nonprofit based in Lafayette that helps Boulder County youth at risk of suicide by removing the financial and social barriers to treatment. Jenna's got previous experience in business management, marketing, and research, and has led numerous fundraising efforts for large nonprofits. Good. Marcy. Marcy Campbell is Boulder County's Behavioral Health Systems Project Manager. That's quite a mouthful. Working to create a behavioral health roadmap for the county. The intention is to provide equitable access to mental and behavioral health support throughout the community. The next community meeting is on February 15th, if anybody would like to be part of that. Marcy brings expertise in community engagement and advancing equity and is involved in youth development, policy and systems change, as well as providing and presenting data to diverse audiences across the community. Okay, so I think the panelists can actually unmute themselves. Would like to do that? Paris? Good, good. So I'm going to go backwards, and I'm first going to ask you, Marcy, what areas give you the most satisfaction and you're most interested in the mental health field? Just a few sentences.
Sure. So I have a lot of experience in doing direct service with youth and young adults before I started doing some of this community change type planning. And I really had the opportunity to hear a lot of stories of young people and families and how they were really impacted in mental health. And so it really is important to me to be centering the community in all of the work that we're doing. And so it gives me great satisfaction to really be understanding the unique needs of community, knowing that community is really a tapestry, right, of so much, so much different need, and just understanding those needs and really working with all of the great partners in the community to do this work together gives me a lot of energy and excitement. I know we have a lot of great need, but we have a lot of amazing people and a lot of amazing community members who want to be engaged in really creating a better community for everyone and addressing mental and behavioral health needs.
Right, thank you very much, Marcy. So Jenna?
Yes. Hi, thank you. Hi, everyone. Thanks for joining today, and thanks for allowing me to be on the panel with all these other extraordinary panelists. I mean, my focus is on youth. Rise Against Suicide serves youth, and really specifically when it comes to mental health, suicidal ideation, and suicidal youth. We don't focus broadly, and I don't tend to focus broadly either. I think by the time the kiddo is struggling with suicidal ideation or they're suicidal and have a plan, that they need immediate help. So that's really what drives me. And part of being driven in that way is because I've experienced it personally as well with my kiddos. And I think going through that is just a reminder, first of all, that we're not alone and that a lot of help is needed for families and for the youth that are struggling in our community.
I completely support that. That's really, youth is really where things are getting very difficult.
Mhm.
Thanks, Jenna. Bill?
Yeah, thanks. And thanks for inviting me. As far as what gives me the most satisfaction, I think since I've been here in Boulder County 20 some years, I've worked in my whole career, I've worked in a variety of settings. So direct service, back and forth with some leadership roles, and kind of working with a lot of different populations over my career. And I think ultimately now that's led me to teaching quite a bit. We have 16 grad students and 4 or 5 externs, recent grads, through Naropa Community Counseling. And for me, having seen everything from, crisis in the emergency room for many years to outpatient care, inpatient care, accessibility issues, I think part of what I enjoy now is both shepherding in our newer clinicians through the terror of what it is to become a mental health clinician early on, and deal with suicide right out of the gates, in your internship. But also to see the reality of the mental health system. For Naropa students, we serve 50% of our clients. We're in the community, not on site. 50% or more of our clients are Medicaid, and we're hoping to increase that number. So we draw a lot of folks that are interested in community mental health care. And then when you get down to the nuts and bolts of it, is we're being subsidized by the university. And because we can't, with what we're charging, serve people that need it and break even. So I'm kind of working towards breaking even a little bit more. But the reality of that is hitting hard some of the students that we're having to raise our prices. And so I think that's another part I enjoy, is engaging our new practitioners as they come into the field with the reality of the mental health field. And even if you want to provide to those that need it, there's a lot of obstacles to that care. And figuring out what those obstacles are, and then encouraging advocacy and other things beyond just being in private practice. So that's a nice tension that I'm seeing, these last couple of years. So that's what I enjoy. I enjoy kind of saying they get upset when we can't serve, and then I say, well, what are we going to do? And so I kind of bring them into the fold of how we're going to problem solve some of this.
Okay, thank you, Bill. Dixie?
Thanks, and thanks for having me. A lot of great partners that we work closely with on this panel. So excited to be here with them. I am Dixie Casford, and what excites me or really I'm passionate about with this work, it started out as direct service. I was a teacher for 10 years and then went into the community mental health field. And so of course that's a passion, is working directly with clients, but I also was strongly drawn to what kind of systems impact can we make at a policy and legislative level. And that's what started guiding me more towards the administrative side. I miss the direct service, but I'm very passionate about looking at systemic issues that exist that can cause great barriers for a lot of our clients. So I'm very, very passionate in looking at those things and seeing how we can collectively address them. When we can.
When you can, yes. We'll get into the nuts and bolts of why it's difficult to do that, hopefully, in a little while. Okay, thanks, Dixie. Kathy?
I too thank you for asking me to be on this. And yes, I do know most of you on here through the Hope Coalition. And I will say that my passion would be kids. I mean, I'm a retired school counselor, and I've worked with adolescents all of my professional life. So working with Coley's Closet students who are high school students throughout Boulder Valley is pretty amazing. I just was in a classroom with a student who was giving a presentation at Centaurus High School. And I will tell you that I'm always proud of what they do. They stand in front of their peers and they talk about a very difficult subject, which is depression and suicide awareness. And I can only tell you that this is my passion. That's why I've stayed with this for so many years. And the other one would be the Parent Engagement Network, which I didn't really say much about, but there's a niche there for Parent Engagement Network where we are looking to help parents understand and work with their kids. So that, and many times as parents, we wonder, how can we talk with our kids? What do we do with all of the stuff that's happening in their lives? And the Parent Engagement Network does direct, we do educational presentations on a variety of subjects for parents to help them get toolkits, a toolkit for how to be with their kids and their youth. So those two, the Hope Coalition, we work with the community as well and do presentations on depression and suicide awareness. So that's sort of our niche. Is we're not broad-based mental health, Hope Coalition and Coalies, but some very important topics right now because of everything that's happening out in our world. So those are my, being helpful and giving education.
Yeah, thank you, Kathy. I know you've been around for a very long time. Yeah,
I have been around. You can see I've been around for quite a long time.
Okay, Paris.
Hello, everybody. I'm really excited because working with NAMI, I get to work on something that's helping people today where they need help. I came from the world of Wall Street, where everything was either quarterly returns, or if you didn't have a 10-year track record, we don't know enough about you to make a decision. And so I thought a lot about long-term planning and retirement and how to help people 30 years from now. And there are certainly people in the mental health space that are doing that. Like Marcy is incredibly thinking about our 10-year plan. What I'm focused on today is helping people right now that need help today. And what's really exciting about mental health for me is that we already have a lot of solutions. We already know a lot of the things that people need. We just need to put them in place. And so what we're focused on is, while we as a society make those systemic changes, how do we help the people that are at risk right now, that are on the streets, that are struggling with existing social services? How do we get those people the help that they need today? Because a lot of people are struggling, as we all know. And I got to see that in real time, that just last month in January, we expanded our support groups to be in-person and virtual. We hadn't done an in-person session since COVID. And there were literally handfuls of people who emailed saying, I've been asking for this for months and months and months and months, and I needed this in my life and I didn't have it. And so getting to see in real time that small changes can affect people's lives in a really transformative way, especially in mental health, where we already have a lot of the solutions. We just have to find ways to implement them, is bringing me a lot of joy in my current role.
Well, thank you very much. Okay, so we're going to jump into the questions. All of you have seen the questions. They're very general, but you'll all have your different perspectives, your different way of seeing those. And so what we're wanting really is the richness of the different perspectives. We're hearing a lot already about youth, suicide prevention, depression. And we know, if you look at the statistics, that those have risen incredibly over the COVID period. I've worked with them myself, and I would say students are really struggling, a lot of them. So that might be one area we can talk about, but let's just jump in. So what's the most pressing mental health needs in Boulder County? Of course, you're going to see it from your perspective, but hopefully we can kind of get a whole view. And I'm going to ask you one after the other, give you about 2 or 3 minutes to talk about it. So I'm going to start with Bill, because you're right in the middle of my screen.
All right, thank you. I think as I saw the panel too, I think, what am I seeing and what's everyone else seeing? So I'll just certainly share from my perspective. I think my first response is sheer demand and access is the most pressing need For Medicaid, I'll hear just a couple of weeks ago. So I heard from a client who was a young mother with bipolar, unmedicated because it'd been rough on medication, a husband with PTSD at home, 2 kids under age 5, and she'd gone through 30 therapists on Psychology Today, and nobody had room for no Medicaid therapists had availability. So every client that comes through our clinic, we screen, because there's myself and one other mental health clinician, two FTEs overseeing about 350 clients at any given time, with 16 students and 5 externs. So we have to judge who's stable enough for us to see, so that if we have too much crisis, we're unable to manage the clinic. And so this young woman was desperate. I had a call, I do a screening and a follow-up to kind of check in. Usually if folks are not on medications, that's kind of or not willing, or not able to be on them, they're not sometimes stable enough. Anyways, we took this young woman, and sure enough, she's had a fair amount of crisis pop up. So it's just very difficult to know how to screen for these, but also when you talk to people, wanting to serve them. So I think the sheer demand of services for Medicaid clients, I think that's a positive, and that Medicaid has expanded and covered a lot more people. But now we're seeing a problem with demand and meeting that demand. So accessibility, and then I would just add to that, and I'll let others speak to things, but we charge $30 an hour for a session. And that's not for, the extremely poor. That's $120 a month. And you have people with copays that's cheaper than their copays, or $50 a month that are, it's touch and go for folks. So we're looking and needing to raise those prices some, but essentially I'm just reinforcing the access point that I think is pretty important to talk about.
Okay, so we'll come back to you. Okay, Marcy, get a different perspective, because Bill, you're right there in the front line. You're seeing those clients as they come in. Marcy, you're pulled back a bit, aren't you? You're seeing it from a bigger perspective.
Yeah. Yep, we definitely are. And so when our team started working on this behavioral health roadmap that we're working on to create a shared vision and plan for mental and behavioral health for the county, we knew that there was a lot of dialogue already about the unmet needs. And so we took a look at all of the existing reports and gaps assessments and dialogues that have happened, community conversations. So we took a sweeping look at those and identified the top 10 unmet needs for mental and behavioral health for our county. And those top 10 needs are accessing the right care at the right time. And so just to name, when I say the right care at the right time, what that means is different for each person. And there's a lot of significant equity-oriented gaps and needs that kind of fit into that space. So when we talk about youth, or we talk about LGBTQ+ community members, or BIPOC community members, or folks who are not proficient or do not speak English, or prefer to have service in another language, all of that's mixed in. So that's a top one. Workforce shortages, so being able to have the right workforce to meet the needs. Really gaps in enough primary prevention, early intervention, and harm reduction support. Addressing kind of that whole person. So the social determinants of health, making sure people have, the financial or other sort of food and housing and those types of needs, because that really impacts mental health. Shortages in supportive housing, shortages in inpatient treatment. Also, there's not enough integration between primary care and mental and behavioral health and information sharing to make that more efficient, as well as just overall system fragmentation is a challenge. And then also the significant disparity that we see in the criminal justice system, and the real need for more mental and behavioral health support for individuals who've touched the criminal justice system, and more diversion needs as well. So we had a community meeting. I know we have one coming up soon, but we had one a couple months back in November, and we shared this list with the community and really got kind of an underscore of, yep, that covers it. We got more details about some of those things, but I think that's kind of our wide scale sweeping view of those most pressing needs.
That is really good. Thank you for your nice, and you've sent me, and which hopefully I'll pass on to everybody, all of the information that you've kind of gathered and where you've got to so far. And I'm assuming these are continuing, these meetings, and is there a final endpoint when you decide on what the strategy is?
Yes, we are aiming towards a June deadline to finalize our behavioral health roadmap strategies. And so we're working with, of course, all the partners on this call in one way or another. But yes, hoping to have that finalized in June and really well supported by our commissioners and of course, everyone who's been participating.
Okay, thanks very much, Marcy.
Mm-hmm.
Okay, Jenna.
Yes. So our mission at RISE is breaking financial and social barriers for uninsured and underinsured youth. Prior to COVID, we did not serve a lot of youth that were not underinsured or uninsured. So let me talk a little bit about that. When we look at underinsured, we look at families. I'm going to give you an example. I had a phone call yesterday with a mom. This family had to pay $2,500 out of pocket to get a psychological assessment done for her child. She is now, the whole family is depleted. They don't have any more savings. So now they can't afford the therapy for that child that has a suicide plan and can't stop thinking about suicide. And so we take them, right? And that child was able to be seen by that therapist today. So she didn't have to wait. But that family, a lot of us would look at that family and say, oh, that family can afford therapy, right? They've got it. They have a house, they have a roof over their head, clothes on their back, food on their plate. That's what we're looking at from the outside. And that's not always an accurate picture that we're being given. And we also have kids that, families that can afford therapy. They can afford to pay out of pocket. But going back to what Bill said, therapists have wait lists for 3 to 6 months. And we know that young people with suicidal ideation can't wait 3 to 6 months. Unfortunately, we had a kiddo who was on a 3 to 6 month wait plan, and he died by suicide a week before he got in to see a therapist. This is what these kids are up against and these families are up against right now. It's the financial barrier. It's a social barrier for our marginalized communities. There aren't enough therapists for them. Our state funded programs are doing the best they can, but right now they're inundated as well. They have 3 to 6 month waits because they're serving everyone. So we still have mental health barriers. And I think another barrier is we don't want to talk about it. Mental health is still very stigmatized. And believe it or not, that is a barrier. Kids in school don't want to talk about the struggles that they have going on in their mind.
Okay, thank you, Jenna. Because that puts it really in perspective, because you're looking at services which have to be there when they're needed, just what you were saying, Marcy. And if they're not, then there is a disaster or a tragedy just around the corner.
Yeah. Mm-hmm.
Okay, Paris, I'm going to go to you now.
I would fully agree with Jenna and Marcy's comments, and I would say the two pieces I would add are complexity and then stigma around the mental health, because mental health is part of whole health. And so if you're not getting the help you need, just like if you're diabetic and you're not getting insulin, you can't function fully. And that stigma prevents people from getting help to go back to work, to potentially getting jobs in the future. I just spoke with a student who, as Jenna was saying, wasn't comfortable sharing about their suicidal ideation because they would be sent back to an inpatient care and they didn't want to be removed from their home again, right? So in terms of the stigma has real life consequences that impact people today. And that adds to the complexity of, it's not just I'm having suicidal ideation and that's all. It's I have a mental health condition and that means that I can't be gainfully employed, and now I can't figure out, I can't afford to live anywhere, and I got a housing voucher from the city, but I can't find an apartment. I found an apartment and it's literally $7 more than my housing voucher, and I can't talk to anyone from the housing office because they're swamped. And right, so the compounding effect that comes from the complexity of both the stigma in our society and also the fact that mental health is not a distinct thing from physical health. They're interrelated, and explicitly mental health symptoms can all be traced back to metabolic disorders. So it really is a whole health viewpoint that we're realizing in the research that is really hard to assess with one thing in a silo, which I can't stress enough how wonderful Marcy and her team have been doing. But putting all those pieces together is almost impossible for someone who has money, time, access, an employer that is supportive. You still can't get access to the care that you need. So if anyone has any sort of additional barrier, it's even more impossible.
Okay, thank you, Paris.
Yeah, sorry. It is, Roland, that sound is how we all feel all day,
I know.
every day.
It's yeah, and you know, we're looking at things which have, as I say, real life consequences very immediately, and people having just terrible suffering. Okay, Dixie.
Thanks, and I don't I don't think I have anything wildly different to say than what has already been shared, but I will just give our perspective, my perspective on some of those issues that have been brought forward. I think whole person care has been mentioned a couple of times, and that is such a focus for us. We've been working with our federally qualified health centers, both Salute and Clinica in our area, to say how do we really approach this from a whole person point of view. We have clients collectively. We have individual clients that trust coming to a mental health provider and not a physical health, vice versa. We have people who are going to social determinants of health organizations but don't trust physical behavioral health. So how do we really get all of these as access points so that people can get what they need where they trust going? And those conversations are so important to continue. Part of that barrier is the funding doesn't always follow that. And that doesn't mean that we can't do it. I'm just saying that is truly an issue sometimes that we do have to just acknowledge how it plays a factor in this. The social determinants of health can't be understated. Marcy, I think you brought it up. Those of you on this call, I think some of the panelists represent our social determinants of health organizations. Those are so critical to what we do in this community, and those partnerships and what the people on this call plus others are doing to support our social determinants of health in these populations is crucial. There's no one organization that can do it all. I think sometimes people look at things as sometimes competition, right? The word competition comes up, and I would just say there's plenty of work for all of us to do, and collectively we have these pockets that we're really good at, and some of us are broad, some of us are narrow. But what I really have loved about Boulder County is historically, I think we all look at that and say, how do we each do well what we can do and work together to do it? And you know, we're not always at our best. For mental health partners, I know people have had access issues getting in. I know that there's some people who haven't had great experiences. And we always want to hear about that. We always look at that as this is an opportunity for improvement. And so just want to say that. I think access, when we talk about that, for mental health partners, Medicaid clients, we can get in. Our average is getting them in within an appointment offered within 48 hours, but usually in within 7 days. There are outliers to that, but that is for a therapist. When we start talking about a psychiatrist, I would say that we're, I think right now at 40-ish days, last time I looked at our data, to get in to see a prescriber. I think it's greater than that in our community. This isn't based on data I've been given. It's here. What I've heard people say is that that can be up to 3, 6, 9 months. And so access means different things to different people. If you need a prescriber right now, then that can be a huge access barrier because you're just probably not going to find that immediately. And the last thing I would add is I think maybe Jenna, you talked about underinsured. Our people who are covered by commercial insurances are there's a big gap for them because speaking just for mental health partners, our commercial insurances cover outpatient therapy and that's it. So if we have somebody coming who has commercial insurance, our full continuum of wraparound services that we have that includes the social determinants of health. It includes health and wellness coaching. It includes prescribers, nursing. That's not available to commercially insured because the commercial insurances won't cover it. So that makes it really, really hard for organizations, and we're not the only one that's facing this, to say you can get all of these services, but you, commercially insured, we can see you for an hour, maybe just 45 minutes a week, every 2 weeks. So, you know, I know AG Weiser has talked a lot about parity and making sure there's parity. And I think that from a policy level, that's something that we keep pushing and staying on top of, to say we need these commercial insurances to open up to other services, because the acuity level of our commercially insured is increasing, and we need to be able to provide services for them that's not just 45 minutes of therapy. And finally, I think I said finally on my last one, so I apologize, but the information sharing is something at a policy level that we definitely stay on top of and advocate for. It is really heartbreaking for us to have young adults is usually where this shows up, where they will not sign a release for their parents, and we are not allowed to share information, and that is so hard. So just from a policy level, trying to figure out how do we do enough information sharing, even among the organizations that we work with that are on this call. How do we do enough information sharing that we can all say, well, this is what I saw, this is what I saw, this is how we could collectively work to help this person. And for a Medicaid provider, that becomes very difficult with the information sharing pieces. So
okay, I'm going to just stop because I know there's lots more, and having been around for a long time, I know how Mental Health Partners has struggled sometimes with getting the money that they needed, the funding, because I can't remember when it was, but it just disappeared at one time. So, you know, it's a really tricky area there. So go to you, Kathy.
Thank you. You know, the 3 organizations that I work with are educational in nature. So this is a whole different way of approaching our community, is giving them information. We don't do direct services. We do some fundraising and then help with the direct, services. But I will say that really in our education, and I'm going to speak to Jenna, what you were speaking about, well, a few Paris did too, the stigma of mental health. And the students in their presentation to their peers really talk about, look, your mental health is like your physical health. You know, if you had a broken leg, you would be getting some help. If you have this feeling, there's a way to get some help. The issue is, where are they going to get the help? I mean, the same access that you're talking about, but we say, make sure you talk to a trusted adult, make sure you find resources, make sure make sure you talk about it. So we do that with the Hope Coalition. That's our message. The same with PEN, Parent Engagement Network, that this is real. These feelings are real, and you can help yourself by whatever techniques and tools that the Parent Engagement Network talks about, as well as what we do in our education. So we're education focused. I'm going to say that the one thing that I've found is with the students, I've just learned about a program, and I'm going to say maybe this isn't the place to talk about it, but at Monarch High School, they have a wellness center. And this wellness center is where students at Monarch High School, if they're feeling like they don't want to, whatever, something's happening in their life, they go to the wellness center, they're excused from their class. There's a therapist, there's a counselor. I know the guy, he's a very good therapist counselor in the room at all times to deal with things that were coming up. It's a very low-key room. I was in it. It felt like I wanted to stay. Low lights. It was really cool. I said, is this happening in all of the other schools? Because, and he said, no, not at this moment, but I'm going, he said he has seen 6,000 people. I mean, there aren't that many, but 6,000 visits. I don't know how many of the same students went there, but over the first semester. And I'm going, okay, we don't have enough counselors. We don't have enough mental health advocates in the schools. This is what we need. But in addition, just to give kids a place where they know they're going to be, they can be quiet and they can be listened to. So that's a totally different subject, but I just
No, but that's
when
good.
I was at Monarch High School.
That's leading into the next question, which I'm going to open it up, which is what populations or problems really are the most pressing? You know, and I made a whole long list: families, adolescents, students, BIPOC, LGBTIQ, elderly, chronically unhoused, disabled, veterans, substance users, and others, which I haven't even thought about. I'm hearing a lot about youth. What are the other places where the services are falling down? And I know it's typically been chronic mental health, because that is the hardest area to deal with. But that's also the area which doesn't make as much noise as any other area, because chronically mentally ill do not have much, in a sense, power in our society. So opening it up for just discussion, who would like to speak to where, particularly from our point of view, where should we focus? How should we be thinking about this for our limited resources, and what do we do to be of support and help to the most important areas?
Can I just say one thing about, depression and mental suicide statistics, that the highest, the age range that has the highest suicide completion is the middle-aged men.
Mm-hmm. Yeah.
Even though everyone thinks it's the adolescents, unfortunately, it's horrible when anyone dies by suicide.
Yeah.
But I would say that middle-aged, the Hope Coalition one time, and we could do it again, did a whole thing on real men do get depressed. And that was, again, an educational piece. And we had a lot of people there going, okay, so what do we do with this? So I don't know what kind of services. That covers all of the ones, Roland, that you put out there as possible issues with mental health.
Right. Yeah. And, as a clinician, that middle-aged men, those are the ones that you watch, because they plan and they do a great job when they do it. Other people are not so good at, if you like, completing their plan. So opening it up to others. Thank you, Kathy.
Yep.
Okay, Paris.
First of all of those populations, right? Like, I don't know how to say everybody, but my husband's a disabled veteran. His mental health rating is preventing him from doing certain jobs now out in the world. And the VA silos veterans away from other mental health organizations. So just right there's a whole other thing that I won't even get deeper into. But to my point, a lot of these challenges are enormous and systemic, and will take coordination across the political spectrum, across county, state, and federal organizations. When I think about from a business perspective, where an additional organization or an additional community could help, the reality is all of those populations need help, but also mental health is health for everyone. And so the more that we, and to Claire's question, reduce the stigma, the more that we can facilitate conversations, because we know it's hard to get into a provider, but we also know that if you're having suicidal ideation and you can find a trusted adult to talk about, that's better than nothing. And so how do we create an environment and create a community where everybody knows that mental health is something that they can talk about, and depending on their demographic, they might go to different places for different types of support, but fundamentally mental health is a human problem, not a specific demographic problem. Is there a way that we can help everybody get more help from an outside business perspective?
Okay, go Jenna.
So there are gaps.
Thank you, Paris, for saying that. Sorry,
you,
I jumped
Paris.
quickly here. Thank you very much.
Where we see a gap, and of course, I focus on youth just because we focus on youth, our organization does. But I'm sure it's a gap for every single one of these groups. When a person is hospitalized for their mental health, they may be put on a 3-day hold, or they may be in there for a week. When that person is getting out of the hospital, there's a very large gap for this person that is typically hospitalized for a suicide attempt or for suicidal ideation. They get out of the hospital and there's nobody there to see them. And 3 or 5 days in the hospital isn't going to take that suicidal ideation away from a person. That person is still at very, very high risk. And that's a big gap that we need to fill with short-term therapy. And again, I say that just because that's what Rise Against Suicide does. It's a short term until we can get people to long-term therapy. And I think we have a big gap in that short-term mental health. And another place I would say too is meeting people where they're at. Mental health can be so rigid sometimes, and it has to be for places like Mental Health Partners, because you know what, they're getting state funds. They have to follow the guidelines, right? But, our therapists, for example, go into schools, like Kathy was saying. Our therapists meet the kids in schools. The kids will come out of class, they'll go for their therapy session, and they go back to class. But we have to start meeting all people, all these demographics, where they're at for mental health. If they don't want to go to an office or can't be seen in an office, many people don't. A lot of our kids don't have parents that can drive them to an office. So how do we start changing the structure of mental health as well, and meet people and families where they need to be met?
I think that's a very good point. One of the things, I just had a client who said, actually, I'm not that interested in seeing a therapist face to face. I find it much more comfortable being in my own room, in my own space, and doing it via Zoom. So there's a big shift in the way in which we can actually help people, through the internet. Okay, so I think, Bill, you put your hand up first.
Sure, thanks. Just to add to what Jenna said there in terms of meeting folks where they're at, I think integrated behavioral health and physical health clinics has come a long way in 20 some years, and doing a good job of that. But maybe there's an opportunity and PCP offices and expanding mental health there, because it's usually one person. Well, that's not entirely true. It's expanded at this point. But there's an opportunity to meet more clients there, I think. Just anecdotally, we're seeing more elderly and outpatient counseling in their 70s, and there's a lot of loneliness. And I think there's a boomer population that's coming of age here. And so I'm not sure exactly what their needs are, but I think where they're showing up more to outpatient counseling, which also says something for that age group, given their own experience of stigma of mental health over the years. The other one I'll just piggyback on kids. I think Medicaid doesn't necessarily reimburse for child advocacy work, but these wellness centers and hiring people to be in them, that might be meeting them where they're at. There's a lot of teenagers that won't go see a therapist, even if they know they need to see a therapist because they just don't know how to do it. They don't know how to overcome that barrier. They don't know how to sit in front of somebody and be irritated and know that that's okay because they're depressed. So I think expansion out of the box of funding for wellness centers, getting more kids contact in schools elsewhere is an important piece. And then I'll just say, finally, we have a partnership with public health as kind of an EAP program, employee assistance for their early childhood providers. Early childhood education providers have been hit really hard with young kids during the pandemic, and the demand has been really high for counseling for those.
Can you just say a little bit more about that? Because I kind of missed which early childhood?
It's all, early childhood, kindergarten centers, daycare / education. There were such problems during the pandemic and staying at home and kids not knowing how to do their emotions, and underpaid people working really hard to deal with mental health and having unconsolable children. And so, I don't know, some level of support across early childhood, providers, educators, just brainstorming, because that ripple effect has been huge on the fallout from the pandemic on the providers.
Yeah. I was just talking to somebody yesterday, and this young kid who's in school, his behavior suddenly changed and he's not speaking to anybody, he's isolating. And then the question is can you possibly find a therapist for him? It's going to be a big struggle. Okay, I'm going to go to Dixie, I think. Oh, Marcy, Dixie, who should I go? How about Dixie?
Let's go Dixie first, right?
Dixie first, okay.
You go in alphabetical, Marcy? Thanks. Yeah, I definitely agree with everything that's been said. I don't think there's one on this list that I would say, oh, that's not true. I think access and underserved fits all of these. I do think from a funding perspective, one of the things that we advocate for is just flexibility in funding to meet people where they are. If they're there are organizations who serve LGBTQIA plus extremely well. Can we have some flexibility in funding to work with them? Because that's the trusted place to go. Same with BIPOC. There are wonderful BIPOC organizations serving populations within our county. And can we have flexibility in funding to do that? One of the things that Mental Health Partners has done is started a community health worker program. And those are people who are getting out into the community, and they're meeting people at various locations within both Boulder and Broomfield counties and working to get them connected to services, not just mental health partner services. They're working to get them connected where they need to be within the communities. We have seen such tremendous success with that, and people have really just the stories coming out of that are so inspiring, and we would love to see that expand. It's an unfunded program, but that is something that's in the legislative session right now to have them be able to bill for their services by 2026. So that's a really important one for us to keep watching, because that would be huge. And then the other thing I think,
can I stop you, Kathy? What's that service? What's that program called, or that service called?
It's community health workers. And so they're not
health workers.
They're not providing therapy. They're we could argue that probably, because speaking to somebody who cares about you and wants to get you to the right place can be very therapeutic. But in the traditional sense, they're not providing therapy. They're providing support to people who need help finding their resources. Okay. So that's been a great program. And then just quickly internally, Mental Health Partners, we know that we have to have clinicians who are from the same neighborhoods, who speak the same languages, who have had the same experiences, and that doesn't just happen. So we are doing a lot of work internally. We're working with a group right now called Groundswell Change. We're doing an equity audit and really doing the work internally to say, what do we need to do in order to become an organization where therapists and others want to come work here, so that we can then better reach some of the underserved populations. And that takes a lot of internal work before that shifts. So that's just something else we're working on.
Okay,
Roland?
Yeah, Marcy, I think. Is it
Roland?
Marcy? Yes.
Real quick, time check, just housekeeping time check. We've got 5 minutes to our Q&A session, right. But we don't have very many questions, so I think you could probably be a little flexible.
Okay, so let's hear from you, Marcy.
Great. Yeah, I agree with everything that's been said. And just to build on what Dixie shared in terms of that flexible funding and meeting people where they're at, I think it's really important to think, and similar to what Kathy shared earlier, getting out of that traditional model of providing mental health support, that one-on-one therapy doesn't work for everyone, and having a possibility to just drop in someplace. We are hearing a lot as we're going out and doing our assessment, and we're thinking about these specific equity issues, about the real need for drop-in services to be available. And it could be something in the vein that Dixie was sharing, but also thinking about community care models. I know there's a knitting group up in Netherlands that they're getting together regularly, doing a little knitting, building some community, addressing some of those isolation pieces that are happening maybe for older adults. And so it's, how do we get outside of the thinking of traditional mental health to think about how do we support community to help each other, for one. So thinking also about our peer workforce, but also just a community member who wants to be helping. Could we have some, let's get a knitting group started, or think about cooking together, or building community in some way that feels really important. And I loved hearing about that. The fact that we've been able to open up and widen to doing both virtual and in-person visits is really great. And there's a real challenge for some of our populations to access virtual services, especially our unhoused folks or folks that have been in the criminal justice system. So it's really important to have still a possibility to go in and access services. And so in our county jail and in the criminal justice system, not only do we have an overrepresentation of folks of color, but we also have an overrepresentation of folks with traumatic brain injuries. And so thinking about an appointment 2 weeks from now at 3 p.m. might be challenging to kind of manage, but having that drop-in support is really super useful and valuable. And I would definitely underscore the representation piece in terms of the workforce. It makes all the difference to have folks who look like you, folks who maybe have similar experience as you, to provide support. And language access needs, I think, are really critical as well. So, all of this is really important. In terms of older adults, something that we're hearing at the county level, Boulder County has a co-responder program, and the county co-responder, there's some city co-responder programs as well. So the county program works with some of our cities, including Erie, Lafayette, Superior, Lyons, and a lot of our mountain communities. And some of the major calls they're receiving are for older adults who are trying to age in place and maybe having some dementia or other isolation or health needs. And so again, thinking about as we have an aging population, what does that look like to have community, especially for older adults living in the mountains? Thinking about, how it's hard to access and go to services. So what does the resource and support look like to go to community members to support that aging in place piece? So I just wanted to add that texture because it may be a little bit different, in terms of needs. But I think all of the populations most certainly have significant needs. And I think it's also worth saying that for youth and young adults, someone really needs to have the expertise in serving a young person, that it's, I like to say one size fits none, and that's specifically true when we're thinking about youth services, that it's really important for folks to have the skill set to be able to work with young people, adolescents, and also children. And so we're hearing a lot of gaps specifically in both of those ages. So what do young kids need? So elementary age, as well as teens and young adults. So I think it's really important to mention that as well.
Okay, thank you, Marcy. So we've got a few questions coming out. The questions that I suppose that we're having to address in SVP is like, where could we impact all of this need? I mean, it's overwhelming. And all of you know that it's overwhelming. And you all know that, as you say, access is not great. There's just not enough services. And I've got a question here about homeless people, you know, people who are unhoused. And we all know that that's a huge mental health and substance abuse issue. And it's getting to be a very big political issue too in this town. So it's like, how do you help that? Is it drop-in centers? Is it more community organizations? What is it? So that's one of the questions. And I suppose the another question is funding. How can we increase the funding? How can we access more money for these? And if you have funding, where's the most impactful place to invest that funding? So, okay, these are kind of huge questions, but so see what you can do with them. Okay, Marcy, you're the policy person.
Yeah. Yep. First and foremost, just in terms of funding, one of the charges that I'm particularly leading on our team is exploring the possibility of a mental and behavioral health tax for Boulder County. And so there was a group of concerned individuals and some advocates from NAMI and folks from Mental Health Colorado and Representative Amabile before she was elected that had come together, and I was a part of that group to think about what could a tax be? Would that be helpful for our community? What would it actually do? And so our county commissioners decided that they did want to formally explore that possibility of a tax. So our team has been charged, and me specifically, with looking into that. And the behavioral health plan that we are developing, part of that goal is to identify the relevant gaps in the community that funding might be able to address. And so the commissioners will be, looking to decide whether or not a tax would be needed. And so they would likely, you may see, if you live within the county, there may be some polling that's occurring in the springtime, as often happens when ballot issues are being considered, to get a sense of what the community might support. And then if the commissioners really do see that need based on the research, that something may be put on the November ballot.
Okay.
And so that could be.
That sounds excellent. I mean, really interesting. But as we know, those things grind slowly. So, okay, I just want to get some other input on that. Thanks, Marcy. Who wants to speak? Okay, Paris.
Well, one thing I've learned is that reducing the stigma is actually more simple than I would think in terms of business problems. Just talking about mental health has an enormous impact on people's mental health. So barring, of course, housing the homeless as the first solution, just reducing the stigma as a culture can come from discussions about mental health, can come from increasing awareness, can come from one-on-one interactions with people struggling with a mental health condition that can't get access otherwise. And you don't always know who's going to be the right point of access, as we've discussed. Like, even with youth, they might not go to a counselor at a school. They might go talk to the janitor because that's the only safe person, or they might not be comfortable talking to someone who might report to their parents what's going on. So just last week, I did a talk at a high school, and I started out by saying, I've had a really hard time going to therapy because I've had a hard time finding therapists. And then the teacher in the class talked about his experience in therapy in college. And now 12 kids sitting around the room went, oh, this is something I could talk to this teacher about. And you could see the shift in their brain of, that would never have come up in the regular curriculum, but by providing a safe space to foster dialogue, we, in effect, lead by example by teaching the community that this is something that it's okay to talk about, and the outcomes of talking about it shouldn't be consequential. They should be getting help or better. And so in terms of the most impact, I think one of the challenges is that there is money out there. It's just very bifurcated and difficult to access. And it makes us in 501c3s have to spend a lot of our time on development instead of spending a lot of our time on actually helping people. And so I think funding those types of roles that we know are necessary, but don't advance the desires of capitalism is certainly a challenge for us in the nonprofit space. But also just creating an environment where us nonprofits can continue to operate and continue to get access to students in schools and continue to create the conversations so that we can reduce the stigma while we're working on big overarching societal changes.
Yeah, so I'm hearing there's kind of the two focuses. You've got immediate need right now, and it's absolutely essential to do that. But you've got this, if you like, change of societal attitude, which is going to have to be dealt with by education, and that's going to have to, so that the next generation, maybe they'll have a whole different attitude. And, you know, over my time as a therapist, I've seen, for instance, I would see like what? 1 in 10 would be men when I first started. I mean, it's a long time ago. Now it's 50-50. It's like, okay, that's a big change. Men are actually stepping up a little bit. So there are changes there, but they're very slow.
Roland, oh, sorry, Jenna, go ahead.
I'm gonna go Jenna next.
Oh, okay. Thank you. I'm fairly new to the nonprofit world, and I started in 2019. And what I've noticed is and this is changing and shifting, but I noticed a lot of nonprofits do things separately. And I think Dixie talked about this because there's competition for funding. And I'm challenged with that concept because really it takes all of us working together. When we talk about whole health, we all need to be working together, and we have to stop, as Paris said, focusing on development so much. It is when we're so hyper focused on funding, or if so-and-so is going to get funding and we're not, that's not helping the people and the boots on the ground. And that's who we have to be focused on. We have to be focused on the people that we're serving. So I would love to figure out how we can work together as one to help the people that we're serving. And I know that sounds very kumbaya, and it probably is, but that's where I'm coming from. And that's kind of what I've noticed in my short time in nonprofit. And the other thought that I had is research. I would love to see more research somehow funded around our marginalized communities. I met with someone who's going to volunteer some time for RISE and do a little marginalized community research, but I don't think we know enough there. As I look at the families that are being referred to us, there's so much more work that needs to be done in those communities. And those communities aren't going to step up and say they want help, nor that they need help, because they weren't raised to use their voices. And so I guess that would be something else. And I think that type of research could benefit every single one of us that's on this call, all the partners on this call. And I would love to see it done collaboratively.
Right. I think that's a really good piece. You probably can tell I wasn't trained in this country. So actually, I worked for the National Health Service. So we actually did have a much more collaborative service. And I was totally shocked when I first came to this country. And now, of course, I got used to the fact that it's everybody doing their thing in different silos. But it doesn't work very well.
No.
Yeah. Dixie, you wanted to say something.
Yeah, I totally agree, Jenna. And I think it can be figured out. I think that for us to have the time to figure it out, I think is part of the issue, right? It's like you're in it and you're doing your day to day. And then you look up and it's like, oh my gosh, okay, I've forgotten this. So that's part of it. The other thing that I would add is, we've talked a lot about increasing acuity and not enough money. And I think and this is a broad healthcare in general perspective when we talk about a national level, but healthcare is really meant for the healthy to fund the not healthy. And I mean that in just a totally general sense, right? And as we go toward, as we the pendulum swings towards not as healthy, sometimes we forget that there's an area of prevention down here that we've taken funding from and maybe put it to the high acuity, and we'll never get ahead of the curve if we continue that. And so there are groups in our counties that are doing amazing prevention work, and sometimes their funding is taken to focus on higher acuity, and then we're never getting ahead of the curve. So I would just say that we can't forget about our incredible organizations doing amazing prevention work, and how do we really, really help support that, because that's what's going to bend the curve and get us back to, you know, whatever we want to call it, but the pendulum swinging back to where it should be. I think that's a terrible way to put it, because it should be all the way to healthy. But anyway, I can't think of the right word, but
So
we
can
can't
you
can't leave our prevention orgs behind.
give me an example.
Of organizations.
Of who's doing good work in prevention.
I think Kathy brought up one, and it's in the chat too, the wellness center at Monarch.
Right.
That is catching people who are just walking in, maybe with low level, hey, I have something going on. What a great way to have them never reach a higher level of need, right? I know that Sister Carmen does some great things. The R Center does some great things for prevention work. There are people doing work in the schools. So
Yeah.
those are, yeah, those are so important. Recovery Cafe, I know, does some great prevention type things. So just, I don't want them to be lost in that conversation as we move the acuity up.
Okay, that's very good, because I've got like a comment in the chat, which is from Alison Billings. And she says, proud to share that Impact on Education is funding the Wellness Center at Monarch, and that we have committed to funding it at Monarch and the other 4 BBSD comprehensive high schools, Boulder, Fairview, Centaurus, Broomfield, for the next school year. So things are moving.
Yes.
Good things are happening. I've got a question down here is the mental health workforce shrinking? Are less people going into mental health than they used to in the past? Bill.
Well, what maybe some other people can speak to this better, but what I've noticed is it's hard to hire. It's hard to hire, I think, and people are making reasonable money in this field now if they go out and do private practice, because interns can now go out into the field and make 120 an hour in Boulder, which is something I never could have done years ago as a new grad, right? And then what I notice is some people will go to someone went to Mine Springs up in the mountains, or community mental health, and the pressure is there, right, for caseloads of, I don't know what mental health partners is, but most community mental health is 32 hours plus of direct client care. And it leads to some burnout. So I think it may not be shrinking, but it's harder to attract them to community mental health, as we're required to do what we need to do to get paid and to keep ourselves financially viable. So I don't know. I'd be curious what others say about it shrinking. I think there's plenty of people going into the field. Naropa's graduate school is expanding in mental health in terms of numbers and applicants, but I'm not sure that they're wanting to go into community mental health. I think that's the challenge. I think there's some, or they do, and they last a year, and then they're like, oh, I can't do this for my own mental health.
It has a bad reputation, you know. It is a sure path to burnout. That's what people say. So other people, jump in. What do you think about this question?
I would just say that, so this is based on information our recruiter has given us, and Bill, it sounds like your group is expanding. Nationally, what he has said, and I can try to get the numbers, is that the number of people going into the field has shrunk. And so there's an effort to catch people in high school to talk about the field of behavioral health and why it's a field that's attractive and mission-driven work. So I don't Bill, it's kind of going against what you said, and I don't
Oh,
have
it's
enough
fine.
information to totally dispute it, but
I'm
it
sure
sounds
you're
like
right.
that could
Some
be a
data.
thing. So yeah, and then, I think workforce for those of us in Boulder, Broomfield counties, especially, the housing issue for the workforce is we've had, I would say in the last 6 months, I've heard of 4 applicants that we've had from out of state who have accepted positions and started looking for housing and backed out and said, I can't live in Colorado. And so it's just, as our counties get more and more expensive with housing, I think that's something that we're just going to have to figure out at some point, because our workforce can't figure out how to afford to live in the counties that they're serving.
Mhm. So I've actually got a question here from Claire, which is working across state lines an issue as well? You've got the whole, registration and certification issues in every single state. Colorado being one of the easiest probably in the country, but it is sometimes still difficult to move from one state to another. And as you say, there's the housing issue as well. Marcy?
I would just add too that there's, in terms of, as we think about our number of providers that are needed and psychiatrists, for example, there's been some policy work to try to get interstate agreements, so that, especially now that we have more virtual, so that a person in Colorado might see virtually a provider in another state. And there are some rules around certain insurance companies and how that works. And I know as I said, there's some efforts, I believe, in this round of the state legislature, some bills that have been introduced. I don't have those bill numbers handy, but that is something that does need to be addressed and can be a challenge. It could be a way to open up our workforce, especially when we get into those real specialty type needs, where there's not as many of those types of providers in the state.
Okay. I mean, it's a very difficult thing when you can't, work in another state. Okay, so we'll move on a little bit from the housing issue. I've got a question here. What challenges have you encountered when it comes to mental health stigma in communities of color? What could be done to remove the stigma in these cultural contexts? We've addressed it a little bit. But as we know, there's a movie recently about Boulder's view of itself, but its reality is not as integrated as it would hope to be. Bill, you've got something to say to that?
Well, I've been working a little bit, beginning partnership with Marina Lagrave and Explorando Senderos. She has started a hiking group with Latinx community, Spanish speaking only, on Saturdays during the pandemic, and got all the families out. And essentially, for some of them, anecdotally, it saved their life, during the pandemic, to get families out hiking every Saturday in a local Boulder County park. And she's brought us in to consider and build ideas of how we can bring mental health further into this community, because the stigma from her perspective is, no, it's and this is not going to be true across the gamut, but for a lot of South American Latinx folks, the attitude is, you're broken, you're going to a shrink. It's high stigma. And so the idea is to start to meet them where they're at on their hiking trips, have them drive this. It's Spanish speaking only. So we're looking into this, right? But the idea is, like everyone's been talking about, go to where people are at. And find a way for them, their community, to drive the mental health provision. So I don't know what that looks like. We hired one Spanish speaker for our internship this year. I do think it's worth putting funding into scholarships for BIPOC, LGBTQI plus therapists. And in some way, I think it's worth looking into that, because we have absolutely so few in this community. Anyways, so I'll just stop there, but that's one small piece about stigma for Latinx community. According to Marina and her knowledge of the community, about a lot of it is, for culturally, it's just, you don't seek help for mental health. You keep it within the family. And so she's working on it. We're exploring that, and I'm sure others are as well. But there's there's definitely barriers.
I like that sense of integrating it to where people are at, doing something which is particularly in the Latinx community, which is much more community oriented rather than kind of one person going off and seeing a therapist, which I don't think is culturally as acceptable. So yeah, the whole idea is how do you make it not just accessible, but that you make it that it's part of people's lives and it's not separate. So who put their hand up? Oh, Jenna.
Yeah, it is interesting. We now have 3 Spanish-speaking therapists. However, 2 of them lack the cultural part. It is very challenging to recruit Latinx therapists because they're busy. Most of them are full. And in terms of the Latinx community, that is part of when I brought up the research. I would love to bring research. I would love to learn, what do they need? I can't assume that I know what that community needs. So what I would like to do is learn and hear their voices and bring their voices together. For me, of course, how do we reach their children? And I do see when we have a Latinx kiddo referred to us, it is more family. I see that family wanting to be involved with our therapist. Even if that child is being seen at school, mom wants a phone call, dad wants a phone call, so we can all stay in that communication. And that is different from our Caucasian kids some of our Caucasian kids that are served. So there's a big difference there. And I would love personally for our organization to learn more so we can learn how to meet them where they're at. And if that is more in the community, how do we create that community? Like RISE, we were just approved to start doing groups within the schools. So our therapists go into schools, they can now go into schools and create groups. Maybe that's how we reach them. So I think it's pretty exciting. I'm with Bill. I want to learn more how to help those marginalized communities.
Thank you, Marcy.
Just quickly, I know the city of Longmont, they were doing an initiative called Supporting Action for Mental Health that's kind of sunsetted, but I know they're continuing cafecitos, so bringing together Latinx parents to have conversations about mental health and really share. And those have been really valuable spaces for reducing stigma, and a lot of parents coming and wanting to be able to support their young people, and then also recognizing kind of that how valuable it is to support each other. And so I think that's really helpful. We also had there was a campaign during the pandemic to call people and check on them. And so that person to person support and just how are you doing really is valuable. So.
Okay, so we're coming close to the end. So what is it, and I'm not sure how much you understand the kind of service SVP does, but basically what we do, we some funding, not that much funding, but we also provide a lot of expertise. So we go in and help with whatever you need in terms of the organization. So for us as an organization, what do we need to know in order to be appropriate and to, if you like, be most effective? It's a very open question. Okay, Paris. I'm going to give you just 1 or 2 sentences.
Yeah, this is in some ways a problem of scale. We need very high touch help for a lot of people. So how do we build capacity to be able to do a high touch type of service for a lot of people a lot of the time? And that's a question that was hard to answer in a for-profit space, but I think that's really what we're looking at is we need to help a lot of people directly. How do we build capacity for that direct access?
That's a very, very good point. And I like the idea of high touch. Is that a technical term that I've never heard of?
Yeah, like a client who needs a lot of attention versus a client who needs just an email once a quarter, right? Yeah, like every person needs a full conversation to figure out what's really going on with their mental health at a minimum.
Okay, thank you, Paris. Jump in. Kathy, you haven't spoken for a little while.
I've been listening. I know lots of needs in our community and a lot of great organizations doing a lot of great work.
Mhm.
Not like we're not doing things. That's the important thing. The Hope Coalition always wants to end our stuff with saying, look, it's not all awful. We are working and we're doing a lot of stuff. I would just say for the three organizations, any kind of funding that helps us continue to give our services for free to our community, our education, all of our presentations, etc. Because to me, that's prevention. If you get to know about, you learn about things in a whatever format, you have some tools to ask questions and maybe know where to go for some help. So that would be,
Right.
you know.
So I'm going to take one more solution from people. Okay, Jenna.
I definitely want to, I want to encourage talking about it. Like, and we can do that without money. When we're out and we're with friends, talk about mental health. How do we start changing the conversation around mental health? It is shocking if you tell someone that you have depression, or you tell someone that your daughter almost died by suicide, how that can start a conversation, and we start breaking the stigma within our community. Because I really, truly think out of everything, it's continuing to talk and have this conversation that's going to start making the change.
All right, thank you so much. And now I'm going to turn it over to Karen. I think you're going to do a summing up. Are you there?
Sure. Wonderful panel discussion, very helpful. Thank you.
I know,
to-
these are amazing people. These are
Yeah.
great people.
Amazing. I thank you to our knowledgeable, dedicated, and very compassionate panelists. Thank you. We do greatly appreciate the work that you do and your time today and the important information and the different perspectives that each of you shared with us. Please know this is a continuing conversation that SVP is engaged in. We will continue to work on this area for the foreseeable future. This is just a part of the ongoing educational process and the work that SVP is doing. Our thanks again to Roland for being our talented moderator, and thanks once again to our terrific panelists for your time and your energy today. Thank you. This now concludes our SVP mental health panel. It is just about 1:30. Thank you for coming, everyone, and have a great day.
Thank you.
And
Thanks for
thank
the
you
invite.
very much.